Yes, loud and clear.
Okay, thank you.
Yes.
Thank you very much. Um, okay. Okay, unless you have a specific topic that you want to discuss, um, we will
Esa
continue
pregunta la voy a quitar.
practicing questions until necessary. Okay, I think it's good to mute the microphones. It is a background noise. Thank you. Very good. Okay, let's see the question that I have here. It says, select which of the following conditions could be associated with delirium. Delirium is a condition that you need to know is an alteration of the mental status with a decreased level of consciousness. So the Glasgow Coma scale is not going to be normal. It's going to be less than normal. It's not going to be 15. It's going to be less than 15. And a part of that, the client is seriously disoriented, and can be very confused and even agitated. The delirium is of acute installation. So it's something that happens from one day to the next or 1 hour to the next. So it's something of acute installation and is potentially reversible in the majority of the cases if the condition that precipitates the delirium, if it is eliminated, if it is properly treated, then this alteration of the level of consciousness, this disorientation, confusion, lethargy that the patient presents will disappear. Delirium is very common at any age, is common in areas where the clients are critically ill, like ICU, but it's especially common in older people. So it can be seen in any person, but it's very common in older people. Uh, Delirium usually have a specific cause that is precipitating, is triggering the delirium. And this is what the question is about. If you have an idea which conditions could produce delirium. So for example, they give you an example, acutely decompensated or acute decompensation of chronic obstructive pulmonary disease. Yes, it's true that this is a chronic condition and the patient is usually adapted to the condition. So the client is rarely presenting delirium when the condition is stable. But when they say acute decompensation with the COPD, of course, it translates in a severe presentation, exacerbation of the disease in which the level of oxygen drops more than usual, and the CO2 and the elevates and the pH decreases. So a respiratory acidosis with hypoxemia. And it happens when the client with COPD suffers of an infection, a pulmonary infection, like a flu, like a common cold, like coronavirus, like RSV, any kind of common respiratory infections. So this condition causes hypoxia, and the hypoxia is a well-known cause of delirium. So we should select this we should select this condition. The other one says acute pyelonephritis. Pyelonephritis is the most severe form of urinary tract infections. It's when the infections ascend to the own kidneys that has a very high, circulation, and now the infection disseminates, generalizes, becomes systemic, and then we have a urosepsis. Urinary tract infections, and many infections are part of this, but especially urinary tract infections are famous because produce delirium, especially in older people. Polycythemia is a condition where the red blood cells are increased as a compensation of chronic hypoxia. Because it is a compensation, and because it is chronic, it is not a common cause of delirium. It translates chronicity. It translates compensation. It translates stability. So it's not the usual. Here we have something that we need to interpret. It's a dark bluish discoloration of nails. This is cyanosis. This is cyanosis. So cyanosis is also a condition associated with low level of oxygen, and the same as A can precipitate delirium. Dementia is not associated with delirium. Dementia is a chronic condition and is one of the differential diagnoses that we need to do with delirium, at least for test purposes. So we need to discriminate what is delirium and what is dementia in a client. Dementia is definitively chronic. It's nothing that happens from 1 hour to the next or one day to the next. It's something that installs gradually, is something that produces cognitive deficiencies like memory, like reasoning, like calculation, etc. But is not affected the level of consciousness. So the client is not lethargic. The client is not, somnolent. There is not depression of the level of consciousness. If you see a client with Alzheimer's or any other type of dementia, drowsy or something like this, it's because secondary effects of medications that are given to them, not because the disease produces that. And the dementia is not reversible, it's progressive. So those are the main difference between dementia and delirium. So definitively no, this is a diagnosis. Diabetes insipidus is going to produce alteration of the level of sodium, the elevation of the concentration of sodium in the blood as a consequence of the dehydration produced by the uncontrolled loss of water in the urine is a possible cause of alteration of the brain, of the neurons in an acute forms. So diabetes insipidus could be a form of delirium. Electrolytes alteration, especially sodium, either high or low, are causes of delirium because there is an acute alteration of the neurons. Too much sodium dehydrate the neuron. Too much sodium overhydrate the neuron. So yes, the alterations of the sodium uh, uh, produce delirium, and this is the way of discerning these questions. As usually happens with the select that apply questions, it is just knowledge. It is just apply knowledge. This is not too much to critical thinking to apply, except to deduct that a dark bluish discoloration is cyanosis, and that diabetes insipidus produces alteration of the sodium. If you have anything to discuss, anything to clarify, please don't hesitate on intervening and just, presenting my discussion and my suggestion about the question, because I noticed that you prefer this way. Okay. The nurse is planning care for a client admitted to the hospital with a diagnosis of acute pancreatitis and controlled hypertension. What is the nurse priority for the client care at this time? Administer an antiemetic medication. Antiemetic medication is for nausea and vomit, like ondansetron or metoclopramide. Manage the client's acute pain. Pancreatitis is associated with acute pain. Monitor the client's blood pressure. The client is suffer high blood pressure, and monitorization is the ongoing assessment of the behavior of the blood pressure uh, that is already controlled in this client. Administer supplemental oxygen. Usually, pancreatitis is not associated with hypoxemia unless there is pneumonitis or pleural effusion in the left lung that can happen in pancreatitis. but it occurs along the time as part of a complication, a rare complication. Of, but a client that has just diagnosed acute pancreatitis is not usual to have hypoxemia. So even if we by ABC, we used to give priority to oxygenation, there is not classically oxygenation problem in pancreatitis. So I think that this is a trick. It is a trap. Uh, if the client have a control of hypertension and monitorization or ongoing assessment of the blood pressure is important, but it's not the priority. They are asking for the priority. So with this strategy, crossing out what we are sure is not a priority in this client. Okay, we are left with the acute pain and the vomit. They don't say that the patient is vomiting, but the pancreatitis frequently have vomit. And there is nothing says there that the patient is in pain, but pancreatitis characteristically has pain. So we assume that the clients can have vomit and the clients can have okay pain. The vomits in pancreatitis are mainly consequence of the ileus paralyticus that usually occurs in pancreatitis. The way of managing the vomits in pancreatitis is keeping the client MPO and introducing a nasogastric suction for gastric suction, for uh, for suctions to keep the stomach empty and to make the pancreas rest. Is not the antiemetic the most effective for the treatment of the vomits in pancreatitis. So if this administration of antiemetic ondansetron or metoclopramide is not the best intervention for the management of the vomits, what is left is the pain. That is no doubt that pancreatitis without pain is exceptional, and the pain tends to be acute. So I used to say we need to dance in the question with the music that is played. And in this case, is the pain. Okay, the music that you are playing is the most important of these options that are mentioned here. So I suggest in this case to choose the management of pain, which is a constant symptom in pancreatitis. In relation with the management of pain, there is indication of the use of opioids, so strong medication, analgesic for a strong pain. Nevertheless, there is a very old polemic about the use of the opioid because in the past it was said that morphine and hydrocodone, etc., used to increase the muscle contraction of an sphincter that is at the exit of the duct that drains the pancreatic juice in the duodenum. And it was by logic assumed that if this contraction occurs, then there is more damage in the pancreas because the pancreas cannot drain the pancreatic juice. And for that reason, traditionally, they recommended the use of the opioid of meperidine, because meperidine it was the opioid that in the studies shows the lowest capacity of spasm or contraction of the sphincter of Oddi. Uh, this theory has been, discarded by evidence. There is no reason for selecting meperidine for the treatment of the pain in pancreatitis. Can be used any other type of opioid analgesic. Hydrocodone is probably the most commonly used. Um, because it's not true. It's not true that it's producing. So this is a polemic that doesn't exist anymore in the literature. You can consult that. By the contrary, meperidine is an opioid that is discouraged to be used, especially in anybody, but especially in children and older adults, because meperidine metabolizes, okay, especially when it's used for more than 48 hours in a metabolite called normeperidine that it decreases the threshold for seizures, so can produce seizures in people. So meperidine is a no-no nowadays. This is tested in Nclex. If you have the knowledge that meperidine it should be avoided as opioid in clients that clinically requires more than one dose of opioid because the risk of inducing seizure. Maybe if you have been practicing in old um, question banks, you can find this discussion about the meperidine versus morphine. It's not valid anymore. It's not in Nclex anymore. The literature rule out, okay, this polemic long time ago, just as a comment. The next question, a client with terminal condition. Okay, so pay attention what means that, okay, is a client that is terminal, is client that is going to die soon. And with DNR orders, okay, and it's DNR, doctor's order, do not resuscitate. Collapses without pulse and respiration while walking to the bathroom. The nurse is called. What the nurse must do next? Inform the provider. Initiate chest compression. So you know that chest compressions is a no-no. And the same to call a code. You don't call a code for a client that is DNR. And you don't initiate chest compression because knowing, as I said, as I stated, that patients DNR initiating chest compression is battery. Okay, it is touching the client without the client's authorization. And then the other option is register the time of death. And they are asking what you do first. I want you to discuss with you that when you see in a question the word next, consider this as synonym of first. And it clarifies our minds because we need to understand what they are asking us to do. And when they say next or first, is a chronological prioritization. So what you are going to do first, to call the provider or to determine and register the time of the death? Of course, you are going first to determine the time that the patient is declared by yourself as dead because has no pulse, respiration, and is unresponsive. So, and then you inform the provider who is going to verify legally that death. Okay, so those are questions of critical thinking, are not knowledge question. And yes, Nclex is full of these kind of questions in which what you need to do is use your logic. Let me enhance the size of this clinical judgment question. The nurse reviews the admission note on vital sign of 64-year-old client who was taken to the ER by a neighbor. Presented to the ER with report of increasing epigastric pain throughout the day. Pain started after dinner last night and usual medication did not help. Stage has been treated for gastroesophageal reflux disorder, GERD, for over 5 years with a variety of drugs. Most recently, omeprazole 40 milligrams orally twice daily. Other medications include ibuprofen, 100 milligrams orally every morning for osteoarthritis, amlodipine, 10 milligrams orally every day for hypertension, multivitamin, 1 tablet every day for general health, and famotidine, 20 milligrams orally before meals, PRN. The vital signs were temperature is normal, heart rate is normal, respiration is normal, blood pressure is a little high, but remember the patient is in pain, and but it's nothing critical. And the O2 saturation is 96% in room air, which is normal. The first question, but based in those data, is based on the medical record information, select 4 client findings that would be of immediate concern of the nurse. So pay attention in this kind of question, because it's something that I commit a lot of mistake, that they are requesting only 4. And pay attention to this immediate. So mm, we need to decide, okay, what is immediate. The fact that the client has a history of hypertension and not having, okay, a hypertensive crisis make low probable that the history of hypertension be one of the immediate needs. We leave, a, a, a question mark there to know. The blood pressure is not normal. It's a little elevated. Okay, so could be another, okay, related. So one is the history, that obviously is not, doesn't require immediate intervention, because is you cannot change the history. And one is the blood pressure is a little high. Let's see if we have for a part of this, of we should include the blood pressure. But blood pressure could be one of the stuff that requires intervention. Increasing epigastric, and it's important, it's a moderate to severe pain. So it is obviously that it is needing immediate intervention. What intervention? We need to find out what is the cause of the epigastric pain. Is this a myocardial infarction? It is an ulcer? Is a gallbladder, what you call that, gallstones? Is a pancreatitis? And the own pain need to be treated, okay, when everything is okay. History of taking famotidine. So definitively, this is not going to be the priority. The oxygen is normal, so nothing. The heart rate is normal. Taking ibuprofen is important. Taking ibuprofen is important. So now we have 2 without doubt in this question. In this question coming from a bank. Okay. So now we need to decide 2 more. This is the way of dealing with questions. Okay. So now we need to decide more. Okay. So the blood pressure is abnormal and, okay, required, okay, continuation of the medication. Okay. So now we are confused, because a normal heart rate doesn't require definitively intervention, immediate intervention or concern. A normal O2 saturation on room air, definitively without doubt, doesn't require our concern or intervention. History of hypertension, history of taking famotidine. I'm afraid that it is a question from a bank, that what is of concern here is not the history of taking famotidine. What is of concern here is the history of taking ibuprofen, because famotidine, which is a H2 blocker, PRN, okay, before meals, okay, should be a concern if it is overdose. If the adequate dose of famotidine is 20 to 40 milligrams per day, uh, uh, mm, it is not well established the patient is taking more than this dose. The famotidine not necessarily need to be taken before meals. Could be taking at night is the best moment of taking the famotidine to block the production of acid at night. So it could be one of the problems. Okay, but the of medication, the one that is concerning is taking ibuprofen with a gastroesophageal reflux disease. And the other is history of hypertension. We cannot do anything about history of hypertension, so you can rule out history of hypertension. So trying to survive in Nclex question, the only biologic problem that could be happening here is that way that the client has been taking famotidine that could be not appropriate. Famotidine should be taken once daily, okay, 20 to 40 milligrams per day, and should be preferably taken at night, okay, when the majority of the acid is produced. Maybe the way that the patient is taking the famotidine is inappropriate, and then it should be changed, this medication. And that's way we can, reach to the four situation, the fourth aspect that the question is requesting uh, us to have immediate follow up. Okay, so notice that what I did in these questions is what I recommend you to do is trying to rule out what you are sure is not the correct answer, and then you are left with a more easier to clarify a scenario where you need to only to decide between history of hypertension, history of taking famotidine, and of course need to be probably the history of taking the famotidine the most probable, even if you don't have exactly the pharmacological rationale for that. For logic need to be that. Remember that to pass the Nclex, you need also a little strategies. Not necessarily you need to know everything, but with the knowledge that you have, you can reach the right answer. Okay. If you don't agree or you want more discussions about this, please don't hesitate in intervening. Based on the client information, complete the following sentence from the list of options provided. So the question says, the statement says, the nurse analyzes the client's relevant findings and determines that the client has, and I need to choose from these options, okay, from these options, okay, one of them is one of them. So it's difficult the way that with the information that are given here without having laboratory is difficult. So what we have is only an epigastric pain that in a client with history of the pectoacid disease that has been requiring the treatment and is taking an offensive medication for the stomach. So you need to choose between pancreatitis that produce an intense acute pain in the epigastric, but radiated to the back. It's radiated, to the back because part of the pancreas is near the spinal cord. This is retroperitoneal, and it produces a lot of vomit. The peptic ulcer disease that produces the epigastric pain and is the number one risk of this client. Gastrointestinal bleeding, we can rule out that because there is anyway anywhere there evidence of bleeding. They don't mention melena, they don't mention hematemesis, they don't mention a fluid volume deficit that should make us suspect that the client is bleeding. Cholecystitis, well, the client doesn't refer history of gallstones. Is not the classical middle-aged obese female, even if we don't have the gender of this client, multipara, that has a acute pain, epigastric, radiated to the right shoulder, or after a fatty meal. So if we are placed in all these predicament of deciding of 4 diseases or at least 3 diseases that can produce um, um, se llama epigastric pain, and we are in this situation. Okay, so if the client has a peptic ulcer, the client can have then a gastrointestinal bleeding, and the gastrointestinal bleeding is not related with ventricular fibrillation. It's not related with bowel obstruction. Bowel obstruction is related with tumors, volvulus, brides, etc., but not this condition. Metabolic syndrome is something chronic, so need to be hypovolemic shock. So if the peptic ulcer is not managed effectively, can lead to hypovolemic shock. So it should be the best way of surviving this question from a question bank, trying to mimic the clinical judgment question that now are part of the new generation question. Continuing the, the, the history of this client while waiting to be examined by the physician assistant, client vomited 175 milliliters of coffee ground emissions. So now, after the previous question, okay, the client present a GI bleeding, probably related with an ulcer, a pecto acid disease. Stay feeling a little dizzy, so it looks like there is decreased fluid volume, that is some hypovolemia that is producing orthostatic hypotension. The heart rate increases to compensate. The blood pressure drops in relation with the admission and is 128 lying down and 112 sitting. So there is a drop of 16 millimeters of mercury and in the change of position, and the systolic, a drop of more than uh, uh, near 20 millimeters of mercury, suggest orthostatic hypotension. Stat blood work is strong. So they want us now to think in a client with upper GI bleeding and having manifestations of fluid volume deficit. Based on the client's information and the nurse analysis, complete the following sentence from the list of options provided. Similar question. The priority need for nursing care is to frequently monitor the client's, yes, is this the one I need to choose? Potassium and magnesium, blood pressure and heart rate, blood urea, nitrogen and proteins, intake and output. Obviously, if we are having a blood loss, we are having hypovolemia, the blood pressure and heart rate is the most important to monitor. To ensure that the client has an adequate what? Intestinal peristalsis? No. Electrolyte balance has nothing to do with blood pressures and heart rate. Acid-base balance has nothing to do with blood pressure and heart rate. Renal perfusion depends on the cardiac output and the blood pressure. So we choose renal perfusion. Okay, um, the story continues. Uh, base, I did. Uh, just a moment, guys. View. Why is this? Out. I did. Lord, I did. Looks like I decrease voluntarily the size too much. Okay, sorry. I need to go to 50. Sorry, guys. Okay, I think that it is. Okay, based on the client's conditions and priority, priorities need, which order by the physician would the nurse anticipate at this time so they'll apply. So returning to our orientation, the client is having a pectoacid disease and ulcer disease and GI bleeding. Okay, start 2 IV lines with large bore catheters. preferably 18. I agree. And why two? Because it's better to have two in a client that is acute. Because if anything happens to one IV, you have the backup of the other. Administer IV esomeprazole bolus. Yes, esomeprazole is a protoporphyrin inhibitor that can be administered intravenous, has intravenous presentation, and is indicated if the client have a GI bleeding. The mechanism of action is to stop the production of acid in the stomach, and it is going to allow the clot that forms in the ulcer to grow and stabilizes, stopping the bleeding, and of course promote the healing of the ulcer. Place the client as a strict MPO, I agree. Why? Because we don't know the evolution of this GI bleeding. We don't know if this GI bleeding can be managed with medications or if the GI bleeding is not controlled by the intervention and requires surgery. Type and cross-match 2 units of packed red blood cells, of course, easy. We know that. Prepare the client for surgery immediately. I disagree. Why? Because this client generally is treated medically. So administering fluid, administering transfusion if it is necessary, using protoporphyrin inhibitors and sucralfate and other medication that stabilizes the ulcers and promotes the formation of a clot in the ulcer, generally is enough to stop the bleeding, and the clients can heal the ulcer with medication. Surgery is reserved if the client it doesn't improve with those interventions that are mentioned here. Start oxygen via nasal cannula, nasal cannula. It is controversial. It is contentious. If the client has a normal O2 saturation or higher, there is no need of administration of oxygen. If the client has a decrease of O2 saturation and the client manifests symptoms of hypoxia, requires administration of oxygen. Okay, makes sense that a client that is bleeding is going to have less capacity of transportation of oxygen and could present drop of the O2 saturation and the oxygenation, but not necessarily. So it is conditional because the only O2 saturation that is mentioned in the scenario is normal. I object giving oxygen, okay, in those clients. Has been very well established that in the past, the oxygen was given liberally to everybody independently of the level of oxygen in blood. Evidence has demonstrated in myocardial infarction, in sickle cell vaso-occlusive crisis, and in many other circumstances that the administration of oxygen when is not needed, so when there is not low auto saturation, can by the contrary increase morbidity and mortality of the client. So it's no good. It's no good. So I object giving oxygen to this client. Give 100 milliliters normal saline over 30 minutes. Yes, it is a bolus of isotonic fluid that is given quickly to replace the loss of volume, the loss of volemia. And monitor the O2 saturation. Yes, I agree to monitor the O2 saturation. Um, okay, so now you notice that we are more uh, short of the answering this part of the expected intervention because we mastered that much better. Um, just a moment. Um, Let me increase the size because you cannot read that. Continue with the same case. Um, the nurse is caring for a 64-year-old client who was transferred from the ER to the medical unit with a diagnosis of upper GI bleeding. The client received esomeprazole bolus that's evident and is scheduled for esophagogastroduodenoscopy, EGD, this morning. So the client is prepared for an endoscopy after being stabilized, okay, the GI bleeding. So the endoscopy is done when the client is stable. It's not vomiting anymore. The client have normalization of the blood pressure. The client is stable. So now for diagnostic purposes, the client is going to have a endoscopy. The upper GI endoscopy is called esophago, gastro, duodenum scopy. Okay, so it's going to see the esophagus, the stomach, and the duodenum, that are the three segments of the GI bleeding, the GI system, the GI tract that can produce upper GI bleeding. Okay, so let's see what they're asking. The nurse teaches the client about pre and post follow-up care that will be received related to this procedure, the upper endoscopy. Indicate which health teaching statements are appropriate and should be included, and which statements are inappropriate for the client at this time. So let's see. You will likely receive a dose of IV erythromycin about an hour before the procedure. Okay, guys, probably if we are in our test and we have a question like this and we see this, we were so surprised knowing that erythromycin is an antibiotic being used for an endoscopy, which is not a procedure associated with infections. The upper GI endoscopy is not associated with infections. It's not associated with, as a complication, infections. The complication of the upper GI endoscopy is perforation, is bleeding, is posteriorly aspiration of secretions, but not infection. Why they are giving 1 hour before the procedure erythromycin? Erythromycin is an antibiotic, it's a macrolide, is used mainly for gram-positive infection. Okay, the rationale for that, it is commonly used, very commonly used, when there is no warranty that the stomach is empty. The erythromycin has the property of emptying the stomach if there is liquid in the stomach. And because the patient has been bleeding, okay, they don't know if there is blood remaining in the stomach, and they want to have the stomach clean to see what is happening in the stomach and to for a better visualization of the stomach. They don't want the blood. They don't want the blood in the stomach. They can give a medication that promotes a potent stimulus to the gastric emptying. So whatever is in the stomach is going to pass here. Is going to pass here, and that's way they are going to have an empty stomach. So erythromycin is frequently prescribed before endoscopy when the doctors could be suspecting that the stomach has content, and either for a better visualization or and to prevent regurgitation and aspiration, it is commonly used by the gastroenterologist before the endoscopies. In those situations, as I mentioned before, that they think that could be present in the stomach some content. So the intervention is appropriate. And it's good to know that. It's good to know that because it's common. It's commonly used. Has nothing to do with the antibiotic action of the erythromycin. It's only related with the gastric prokinetics, potent prokinetic action of the erythromycin. The second, you will be given general anesthesia, so you won't feel anything during the procedure. General anesthesia is used for surgery. General anesthesia has complications, has side effects, side effects, and is not used if not necessary. What is used in endoscopy is conscious sedation. So the client is going to be sedated, but is not going to be under anesthesia. So it is inappropriate. Usually the sedation for endoscopy either is done obtained either with a benzodiazepine like midazolam, okay, or a low doses of propofol and hypnotic. Yes, so this is generally what is used. It's not used general anesthesia. So you don't agree with that. It's too risky for the client. Remember that the anesthesia that is applied is local, okay? It's in spray in the throat, okay? In the throat. Mainly to inhibit the gag reflex. Your throat will be sprayed with a local anesthetic to help reduce your gag reflex. You know that is true. We just mentioned that. After the procedure, your vital signs will be carefully monitored, of course. Why? Because the client's at risk of bleeding or having complication of the endoscopy like perforation, etc., can affect the vital signs. You will continue to be MPO after the EGD. Yes, it is true, because remember that it's going to continue MPO until the gag reflex returns and until they decide that the crisis has been overcome and the client is able to restart the oral feeding. No problem with the question. Okay. This question that I find and copy and paste here are more to practice the style of the question more than the type of knowledge that they use to test in English. Okay, so no doubt, no interventions. Okay. Okay, using the iceberg identification, situation, background, assessment, and recommendation. Format. Click to highlight the text that expresses the nurse recommendation to the physician. So of these four, which one is a recommendation? So you have a client reported a cough and shortness of breath while resting. It sounds more like a situation. The patient has shortness of breath while resting and cough. It is the situation, not the recommendation. The onset of symptoms was sudden and not relieved with the client's position at 90 degrees. It is part also of the situation. Vital signs, oxygenations, and auscultation, it is assessment. Rapid response was called because of unstable signs. Okay, this is what the nurse considered necessary to do and is informing the doctor what the nurse did. So it could be what the nurse recommended, okay, and did, okay. So could be this the answer. Dr. Smith was notified to obtain diuretics and critical care monitoring orders. Okay, so Dr. Smith was notified. It is the documentation, because it is Dr. Smith, the one that you are calling uh, uh, to 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 do that. It is documentation that you did. So you rule out this, you rule out this. You have now B and excuse me, C and D as the possible recommendations. What do you think? Can you help me? What did you consider recommendation? Somebody can help me?
D as in dog?
D as in dog. Okay, so it is what you recommended. Okay, to do diuretics, critical care monitoring orders. Yes, so this is okay, obviously the recommendation. So notice that you start ruling out what is definitively not. then you are left with the two that can more similar to, and then you quickly reach your right answer. Perfect. The newly graduated nurse refuses to instill sterile normal saline solution before suction a tracheostomy tube when ordered by the physician. It is interesting. In the past, remember that the protocol changed based on evidence. In the past, in tracheostomies, and also in the tracheal tube, in tracheostomies, okay? It was a routine that when we were, okay, suctioning a tracheostomy, we instill with a syringe and a small amount of sterile normal saline, okay, to lose the secretions, and then after that, when you suction with the catheter, you got okay more efficient okay cleaning of the airway, okay, because the secretions were loose by the normal saline that you instilled before. Never that, and it was a routine, it was a protocol in the past. I remember learning that. But evidence demonstrated that the external parts of the tube are more colonized by bacteria, are more contaminated with bacteria than the deeper part of the bronchi, of the airways and the lungs. So what you were doing when you instilled the normal saline was sweeping, moving the bacteria from this area to the deeper area that were stable. And the evidence showed that this policy increased the incident of nosocomial pneumonias or ventilator-associated pneumonias or pneumonias acquired and respiratory infections acquired. So now it is a no-no. You can find in your practice people that could be outdated or don't follow okay evidence, and then you can have this kind of conflict, and this is what is described here. The newly graduated nurse refuses to instill a sterile normal saline before suctioning a tracheostomy tube when ordered by the physician. So there is a conflict there based in your knowledge. The nurse supports the refusal, referring to an evidence-based practice recent update. Which ethical principle apply to this situation? Beneficence, justice, non-maleficence, autonomy. What do you think, guys? We can rule out autonomy because this is nothing to do with the decision of the client. We can rule out justice because there is not a situation that is not just. As I say, it's not a situation where you are, discriminating or being unfair. So it's between beneficence and non-maleficence. Is to do good or to avoid doing harm. What you select?
Non-maleficent?
I agree with you, because if you know that if you do this, you are going to produce harm, and you say no, I'm not going to do that, is non-maleficence. Do you see now the difference between beneficence, do good, okay, do good, do what the patient needs, versus don't do what could harm the client, which is non-maleficence, okay? This is the big difference between beneficence and non-maleficence. Very good. After receiving the shift, which of the following clients should the nurse see first? First, a priority. First, a chronological priority, because we need to look for the client that is on worse, the client that is needing our attention first. We have a client with diagnosis of ulcerative colitis. Remember that you are receiving your shift, all the clients are hospitalized, or the client has been already diagnosed, or the clients have already evaluation by the physicians and are receiving treatment. But you have 4 of those clients, and one has ulcerative colitis, okay, diagnosed, who is reporting 4 loose blood streaked stools in the past 3 hours. So is having a um, loss of feces with blood, um, um, and is diagnosed with ulcerative colitis. We know that this is a characteristic of this disease, frequent bowel movement with mucus and blood and pain. Uh, the risk of this client with ulcerative colitis is going to be dehydration, fluid volume deficit, and electrolyte disbalances. Could be infection, because remember that they are at risk of developing the toxic megacolon, in which they can develop sepsis toxicity. But it's not described here neither symptoms of dehydration nor symptoms of toxic megacolon. So those are risk situations. And usually we don't see first the risk. We see first the actual problems. Intestinal obstruction, who has a nasogastric tube connected to intermittent suction and who is reporting abdominal pain. Okay, why the client is reporting abdominal pain? Okay, it could be a complication of the uh, problem, or the nasogastric should not be working. So it looks that this is more unstable than A. Let's continue because we need to analyze all the cases. Transurethral resection of the prostate 1 day ago. Oh, has 24 hours. Has an indwelling urethral catheter and is reporting bladder spasm. Bladder spasm is a it's called tenesmus. It's like a painful sensation that you want to pee and pee is not coming out. It's not coming out because the pee is coming continuously through the indwelling, okay, catheter. Is a common finding in after this surgery in clients with the catheter. Requires medication, uh, but it's not life-threatening. Right lung lobectomy 2 days ago. Has 2 days. One piece, one lobe of the right lung was removed and has a chest tube with fluctuations in the water cell chamber of the closed chest drainage system. Okay, fluctuations is expected in the water seal chamber. So it is expected this client to have a chest tube, and definitively it is not. It is okay. The client with the spasm is expected. You need to know that it's common, it's expected. It's not nice to have a surgery down there and to have Foley because you have bladder spasm. You need pain medication. So it's between the ulcerative colitis that is reporting something that is expected in ulcerative colitis and has already treatment. And there is nothing describing any other complication like dehydration of toxic megacolon. So it doesn't look to be this. And then we have a client with intestinal obstruction, has a nasogastric tube connected to intermittent suction, but is reporting abdominal pain. Why a client with intestinal obstruction that is receiving what must receive, which is a drainage of the content with a nasogastric tube, is reporting abdominal pain? Possibilities? Well, the possibility number one is that the nasogastric tube is not working. And because it's not working, because it's obstructed, because it's kinking, whatever, then liquid is accumulating in the stomach and in the intestine, producing the colics and the pain. This is something not expected that require intervention. Other possibility that a non-expected complication is happening in the abdomen and require your assessment. Of the 4 clients, obviously, the one that is having something non-expected and requires your first attention is B. This criteria of course, the first criteria is ABC, ABCD. And the next criteria, when everybody is breathing okay, everybody has stable circulation, the next criteria is expected versus non-expected. Is not expected abdominal pain if the client has intestinal obstruction, just intestinal obstruction with the drainage working properly. Something's wrong there. The other stuff are expected. The nurse is providing teaching to a client going to a rhinoplasty. Rhino is anything that had to do with the nose. Rhinitis, yes. And plasty is a surgery that corrects deformities. So people have a very big nose or deviation of the septum, etc., can have this type of surgery. The nose is used to breathe. The nose is located uh, near the airway. So any surgery here in the nose can bleed anteriously or posteriorly. Okay, and is the most important to have in mind. Okay, bleeding. Uh, okay, which of the following statements requires the nurse follow up? Follow up means that is something wrong and you need to make more assessment and maybe an intervention. If I need to sneeze, I will keep my mouth open. It is correct. This is a technique that you need to teach clients that need to sneeze or need to cough, because sometimes you need to do that. And you don't want pressure to build up, okay, in the areas of the airway and the head and the neck and the chest. It applies to sneezing and also to coughing. When you sneeze, you first close your mouth, close your airways, and builds up pressure, and then suddenly release the pressure in a noisy explosion. The same happens in when you cough. When you cough in normal way, you close the epiglottis, okay? And then you build up pressure. You do an intense valsalva, and then your epiglottis opens violently, producing, okay, the violent explosion or release of the air that is very effective to clear the airway. But there are surgery in the brain, there are brain hemorrhages, there are brain edema, surgery in the eyes, surgery in the ears, surgery in the neck, like thyroid. Uh, in this case, they know that you don't want this trauma, this explosion, this building up of pressure, which is a valsalva that could be contraindicated, and then the explosion, the trauma of the air blown violently. And the way of avoiding that is telling the client, teaching the client to cough and to sneeze with the mouth really open, widely open. This is going to prevent the client from doing valsalva and to building up pressure. So it is correct. Sometimes this is called half cough, just in case you have that in it is. This is frequently called half cough. Okay, uh, coughing and sneezing with the open mouth. So it is correct. Doesn't need any follow up. I can take ibuprofen for pain and inflammation. You know that ibuprofen is not the ideal analgesic and anti-inflammatory medication after surgery. Why? Because ibuprofen, the same as aspirin, inhibit the platelet aggregation. This promotes bleeding. And one of the most feared stuff in surgery in this area is bleeding, because tends to be posterior bleeding and can affect the airway. So I'm concerned with this statement of the client. and concern. This is concerning. Let's see the others. But all we need to check all. I don't need to modify my diet while recovering from the surgery. Okay, nose doesn't require changes in the diet. There is no need of soft diet. There is no need of restriction of liquids. There is not a rationale for modifying the diet. The chewing and swallowing is not affected by a surgery in the nose. So it sounds that it's okay. And I cannot shower while having my nose packed with the stent. Looks like they left the stents in the nose. Of course, there is a dressing there, absorbent dressing, so doesn't make it makes sense that allowing the water of the shower no damp or moist the dressing is inappropriate. So I think that everybody agree that B is the concerning and is the one that we are going to object and follow up and clarify the client. The nurse student asked the preceptor about the etiology of the aplastic anemia of one of their clients. Okay, the anemia can be because deficiency of factors needed to produce hemoglobin. The most important is the iron deficiency anemia, but also can be deficiency of B12 that produces the pernicious anemia, or the folic acid that produces also a megaloblastic or macrocytic anemia. Other cause of anemia is the over destruction of the red blood cells that are produced, like happens in hemolytic anemias like sickle cell disease. But one dramatic form of anemia is the aplastic anemia, where the bone marrow is damaged. And not only the production of red blood cells is affected, also the production of the white blood cells and platelets. And this is called aplastic anemia. So a brief refreshment of what is aplastic anemia. Remember that aplastic anemia is sometimes related with medications. And Nclex love to ask you if you know the most common medication that produces bone marrow depression. Clozapine is one of the preferred. Remember that clozapine is an atypical antipsychotic medication for schizophrenia. Carbamazepine, which is an anti-epileptic medication, carbamazepine, okay, is another medication that Nclex loves to ask you, producing depression of the bone marrow and the long-term aplastic anemia. Other medications that can produce aplastic anemias are the propylthiouracil, used for the treatment of hyperthyroidism, Graves' disease, and of course, any kind of chemotherapy medication, like methotrexate, like cyclophosphamide, etc., etc., or the medications. So have that in mind, especially these two, carbamazepine and clozapine. So in the bone marrow, you are going to produce the white blood cells, the red blood cells, and the platelet. The red blood cells live around 4 months, 3 to 4 months. Okay, so it's going to live a lot of time, 120 days. The platelets live 7 to 10 days, and the white blood cells, once they are produced, live hours. So of these three lines, the three lines are going to drop when you have bone marrow depression. But of the three lines, the first that is going to be noticed is the drop of the white blood cells, what is called the agranulocytopenia. Yeah, the agranulocytosis. Agranulocytosis is what you see as a complication of bone marrow depression. That is the earliest manifestation in which the white blood cells drop. The clients start presenting infections, easy infection, fever, and infection in the throat and the mouth, which is the first to get becoming infected. Then start the problem of bleeding. After 1 week, you run out of platelets, and then you start having bruises and bleedings, okay? And then the last to develop is the anemia. This anemia is called aplastic anemia, okay? So this is a brief review of what is aplastic anemia associated with bone marrow depression, because it's the origin of the aplastic anemia, and is the only anemia that is accompanied by a significant problems in the white blood cells and the platelet, because the other anemias, the one that we mentioned before, the white blood cells and the platelets are not affected. Okay, so a brief mental review, because it's the purpose here, preparing for the Nclex, okay, to remember the most important. So going back, the nurse asked the preceptor about the etiology of the aplastic anemia of one of their clients. What is the correct answer? The preceptor: aplastic anemia only affects hemoglobin and red blood cells. It is not true. Affect the three lines. Aplastic anemia is a severe condition caused by B12 deficiency. No, B12 deficiency produces the how you call that, pernicious anemia, that is only anemia, is not affecting significantly the number of white blood cells and platelets, but is anemia plus damage of the myelin. So there are neurological problems. The problem with the B12 is needed to synthesize myelin. And because a part of the anemia, the client is going to have myelin deficiency, the nervous system, peripheral and central nervous system, is going to be affected. So you're going to have numbness, tingling, peripheral neuropathy, unsteady gait, and you also have cognitive problems if the disease is not diagnosed and treated, uh, like dementia. Okay, this is the pernicious anemia, but it's not aplastic anemia. Aplastic anemia develops when iron deficiency persists for a long time. No, this is another deficiency anemia. It's the iron deficiency anemia. It's not aplastic, so it needs to be the last. Aplastic anemia presents as a consequence of the function of the bone marrow stem cells. This is the answer. Okay, so a brief review of what is aplastic anemia. Those clients usually require transfusions because the bone marrow is unable to produce the, the, everything, but transfusion of platelets, transfusion of the white blood cells, transfusion of red blood cells, okay, uh, placing the clients in reverse isolation, etc. If the bone marrow recovers because it was something transient, chévere, okay, no need of anything else. If the bone marrow doesn't recover, then the client needs a bone marrow transplant. Next. A client diagnosed with bipolar disorder is in a maniac phase with combative, okay, behavior. And initial, so they kindly put that in capital letters to remember initial. So the first that we do, nursing priority, it is a redundancy, but it's good to understand, okay, is to provide adequate hygiene and nutrition, decrease environmental stimuli, slowly involve the clients in unit activities, administer and monitor sedative and mood stabilizing medication. We need to go to Maslow priorities, the pyramid of Maslow. So what is in the base? The physiological needs. Which one are physiological needs? A, nutrition, sleeping, hydration, hygiene. Client in maniac phase, okay, they because the hyperactivity of the brain, they don't have time to eat, they don't think in drinking, they are continuously moving, they don't sleep, they don't take care of their basic needs. And that's the reason for which we need to provide finger food with high energetic or caloric content and nutrients content, because they have loss of weight, deterioration of the nutrition, appropriate hydration, promote sleep, and of course, okay, promote hygiene. This is the priority. The other aspects here are psychological, and we know that the psychological needs go after the physiological needs. Are correct, but are not the most important, are not the initial, are not the priority. The nurse carrying out the skin assessment of a male paraplegic client observed a reddish discoloration of the sacral region without blanching. So if there is no blanching, I have a stage 1 pressure ulcer. I already have a pressure ulcer. Even if the skin is continuous, has not been broken, but I have a stage 1 pressure ulcer in the sacral region. The client's paraplegic, okay, in it could explain pressure, it could explain friction, it could explain hearing, and even could explain incontinence, maceration. Those are risk factors for a pressure ulcers that are included in the Braden scale. Okay, this is a scale that you need to know. The Braden, Braden, the Braden scale that is including all those risk factors. Well, observe the CNA or the UAP providing care which the following action requires the nurse follow up. The CNA applies a skin barrier ointment on buttocks and sacral region. Perfect. Skin barrier basically is petroleum. And yes, separate the skin from sweat and from urine, etc. It's okay. The CNA, the UAPs can apply that. Places a folded pillow on the client's back before turning from lateral to supine. The CNA is supposed to change position of the client at least every 2 hours, if not more frequently. In this client that has already stage 1 should be done more frequently, okay? So the client can be supine, the client can be either lateral, right or left lateral, and can be prone. Those are the 4 positions that the CNA and the nurse can place the clients. But when the time for supine position arrive, if this is the mattress, okay, if it is the mattress, and this is the client, this is the shoulders of the clients and the head of the client, okay, to move the client from lateral to supine, okay, from lateral to supine, because 2 hours have passed, you need to place a pillow, okay, you need to place a pillow in the client's back. So a pillow should be here in the client's back, okay, in the client's back. So when you move the client to supine, there is a you know, this floating because the pillow prevents the back from making total contact with the mattress. The back is going to be like floating, and it is going to decrease the pressure in the sacral region. That is the one that is it is you know, harm here, is having the problem. So this is correct. Okay, so if you never, you know, work in changing position of the clients, remember that it is the correct technique. Placing a folded pillow in the client's back, okay, in the upper back, before turning the client from lateral to supine to keep the sacral area floating, offloaded of pressure. Elevates the head at the bed at 45 degrees with or semi-Fowler, and applies a condom catheter to manage incontinence. Condom catheters can be applied by the CNA, so it is correct, it is correct. And yes, it is correct, so need to be C. Why it is not good? When you have in the sacral area, okay, pressure and a problem, you need to avoid elevating the head of the bed more than 15, 20 degrees. Why? When you elevate the head of the bed so much, 45, okay, the client is going to slide following the gravity force, because the heavy body is this part, and the gravity force is going to make the client slide, okay, over the mattress in this direction. It is going to produce a force here in the sacral area that is the one that is doing the maximum contact with the mattress. This force is going to be opposite, while the bone and the muscles and the core of the body is going down, the skin is going to be attached to the mattress and is going to go in this direction. This is a tearing force. This is a tearing force. This is what they refer as tear. And the tear affects especially the sacral area. A part of that, the sliding is going to produce friction, and the friction is also a risk factor for pressure ulcers. If you keep the client not such elevated, if you keep the head of the bed not such elevated, then there is less pulling of the gravity for less sliding down, less tearing, and less friction. That's why this elevation is too much for the client. Okay, a brief review of positioning of client to prevent pressure ulcers, specifically sacral pressure ulcers. Next question. The nurse knows that some conditions require to be assigned to a quiet room with decreased noise, decreased light, few interruptions, and stimulation. So there are some diseases that requires a quiet with environment with decreased stimulation, which pathology have this requirement, these requirements. Depression. I hope that you disagree. Depression needs stimulation. If you are depressed and then you're placed alone with little stimulation in the dark room, I think that you are going to be more depressed. But migraine benefits from these conditions. When during the migraine attack, okay, the client should be have decreased light, decreased noise, because there is a phonophobia and there is photophobia, and avoid talking to the client unnecessarily, avoid unnecessarily stimulation. Preeclampsia. Preeclampsia is a condition that increases risk for seizures. So the client needs to be placed in seizures precautions. The seizures precautions include those conditions: quiet, dim light, minimum stimulation. Okay, so it is requiring these characteristics. Alzheimer's dementia is the same as depression, requires stimulation, of course, not overstimulation, but stimulation, like reminiscence, remembering, like play, like social gathering, etc. So I hope that you disagree. Bipolar mania. Bipolar mania requires these conditions. Bipolar mania is better to have the stimulation decrease. So the noise decrease, turn off the TV, turn off the radio, keep the client in a quiet environment, always supervise, but in a quiet environment. Avoid excessive interaction with other people that could participate in a competitive behavior that could upset the client, especially during the mania, okay, phases, okay? So decreasing stimulations in bipolar mania is okay because the patient has tendency to suffer of insomnia. It's better to provide a room far from the nursing station where there is more quiet environment, because this client has no risk of suicide. Okay, so that's why it is applied. And tetanus. Okay, lockjaw. is a disease that you don't know, thanks to something called vaccination. So all those people that are against vaccines need to reconsider the history of the mankind, the history of the ¿cómo se llama? Of the medicine, that in the past horrible diseases existed, and I personally, knew about cases of tetanus because in the third world, okay, from where I come, not everybody's vaccinated like here in America, no? And at least in the past. And tetanus is a horrible disease that any stimulus, noise, talking to the client, a light, touching the client will produce an spasm of the muscles, and the client is going to be an arc, okay, an arc, because involuntary contraction of the muscles, okay. This is the client, okay. This is the client, okay. The client, okay. The client is going to be like an arc, okay. It's called opistotonos, opistotonos, okay. And if you touch the client, if you talk, if you talk aloud, if there is too much light, you turn on the light, the client is going to make this. And fractures can occur in the vertebrae, dislocation of the shoulders, etc. It's horrible, and it's very painful. No? So a brief explanation of condition that requires decreased stimulation, contrasting with other conditions that, by the contrary, you need to stimulate the client. It was a question in English. A female client is admitted to the hospital with a medical diagnosis of decompensated hepatic cirrhosis. When taking the client history, the nurse should follow up with finding what is concerning, what need more assessment, what need intervention in a client that is admitted with cirrhosis, hepatic cirrhosis, decompensated. The client is taking the diuretic spironolactone. It is a potassium-sparing diuretic and is the diuretic of choice. I mean, the best diuretic for the management of ascites. The only contraindication of spironolactone is renal failure. They don't mention that the client has renal failure, so it doesn't look to be an issue. The client is following a low protein diet. Okay, we are going to discuss that later. Let's see the other options because it is depends. The client shave legs with disposable razors only occasionally. It is of concern. Why? Patients with cirrhosis have coagulation problems because remember the coagulation factors depending on vitamin K are synthesized in liver. Because the liver is damaged, those coagulation factors are not produced. So it's like if if the client were taking warfarin. So we know very well that shaving using disposable razors that have straight razors is not electrical clippers, okay, is contraindicated as inclined that should be in how you call that, bleeding precautions. So it is a big problem. And then the client is taking propranolol 3 times daily. Propranolol, a beta blocker, is used for the treatment of portal hypertension. You know that in cirrhosis, the portal vein has increased pressure and it translates in ascites and esophageal varicose veins. The propranolol decreases the pressure in the portal vein, improving those conditions. So it is okay. So no doubt that taking propranolol and taking spironolactone is okay and expected in patients with decompensated hepatic cirrhosis. In relation with the low protein diet, the proteins degrade in the body in ammonia. And the ammonia is transformed by the liver in urea, blood urea nitrogen, and the urea is excreted by the kidneys in the urine. If there is liver problem, there is an accumulation of ammonia. Uh, the clients with cirrhosis not decompensated requires a normal protein diet because they need to repair, have nutritional needs. Okay, they have tendency to have malnutrition, so they require a normal protein diet. But when there is a decompensation, an important decompensation, it depends, is variable. Doctor can order a transient, not permanent, a transient uh, reduction or control in the amount of protein intake to reduce the production of ammonia together with the lactulose. So it is not so bad. It depends. So what is definitively the priority here, the safety issue, that the clients can cut with the razors and have a coagulopathy and can then bleed too much. So C is the best answer for this question. Something similar happens. Summarize it. Don't forget that clients with cirrhosis, with hepatic insufficiency, have bleeding tendencies and should be placed in bleeding precautions. Is the, the taking home okay message. Next question. The patient with cancer needs an initial course of treatment with continued maintenance treatment and ongoing observation for signs and symptoms of over a prolonged period. Okay, so it is a client with cancer that is going to be treated with antineoplastic medication, I assume, and later is going to continue treatment and ongoing observation. Which patient statement is of greatest concern? Let's see. My symptoms will eventually be cured, and so happy that I don't have to worry any longer. It sounds not realistic, no, because cancer not necessarily is going to be cured and always need to worry because it requires follow up. So it is concerning, but the question is, is it the greatest concern that the client needs a reorientation, needs more teaching? Maybe no. My doctor is trying to help me control the symptoms. I'm grateful for the extension of time with my family. It is perfect. There is nothing concerning here. It is perfect. Okay, this is realistic. Okay, so the treatment can extend my life. Okay, I'm going to enjoy the extension of my life. Okay, the opportunity given me to live a little, to live more, not little, live more, and enjoy this time with my family. No problem there. My pain will be relieved because I'm going to die soon. So it is concerning. There is nothing in the scenario that say the patient must die soon. And the patient is happy because feels that the pain and all the discomfort and the suffering of the disease is going to end. I like to have control over my own life and death. Okay, so what sounds this to you? A patient with cancer that says, I want to decide, okay, over my own life and death. What sounds to you? Yes or not?
That they're ready to go.
Is ready to go, but under his or her own conditions. So the client sounds suicidal. The client sounds suicidal. Yeah. So my pain will be relieved because I'm going to die soon. Why die soon? If the client is in treatment for cancer. The the purpose of the treatment for cancer and the observation, ongoing observations and the symptoms, etc., over a prolonged period, it doesn't include dying soon. And to complete, the client is stating he or she wants to have control, okay, over his own life and death. So it sounds suicidal. For initially, I may have to take some time of work for my treatment. I can probably work full time in the future, probably. So it is okay. It is realistic, okay? That while in chemo, is not going to be able to work full time, need to take some time off the work, and if they get better, they could work again. So it sounds realistic. So between 1 and 3. One is a client that is disoriented. It needs more information. There is no guarantee of being cured. Sometimes yes, but there is no guarantee for that. Okay, and not having need of worrying anymore is totally unrealistic. But it is a problem of education, of teaching. You know, while 3 is a client with cancer that is going, okay, to chemo, okay, because our patients with cancer uh, 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 that are going to have treatment, chemo, or any treatment with maintenance treatment and ongoing observation over a prolonged period of time. Okay, which one is more concerning? My pain will be relieved because I'm going to die soon. I know when I'm going to die. And I like to have control over my own life and death. This is a client that is having suicidal plans. So he or she have control over his or her future. Have decided to die soon. The pain is going to stop, and they say that have to have control over that. It is the most concerning of everything. Suicide is something that Nclex tests a lot. Suicide is something that you need to be diagnosing suicidal ideation, diagnosing in all your patients. The policy, the recommendation, the policy in nursing and for your anchors is that we need to avoid the suicide, because evidence say that the majority of the clients that we prevent the suicide after a while become grateful, okay, and happy and benefit of our intervention to avoid the suicide. Okay, and is one of the exceptions of exerting autonomy. Okay, and is based in evidence that people when thinking suicide is thinking in a definitive solution to something that usually is transient, is not permanent. So you should not have definitive solution for something that is transient. You understand? Doesn't make sense. And they realize that after the suicide has been aborted, has been, impeded. And it is important for you to have this idea in your English, that there are signs, there are comments, there are statements that make you suspect that the client could be suicidal. Okay, and clients that have been diagnosed with serious diseases can consider suicide, and especially the disease is has no cure, etc., etc. Um, so this is the purpose of this question, and mm, to develop this awareness on you in your English, that sometimes the way that they present the scenario is not so overt, is not so evident, and you need to suspect suicide, especially in client with neurological diseases that have no cure, clients with cancer, etc., etc. Remember that when a client uh, is depressed and decides to commit suicide, becomes elated, becomes like euphoric. Why? Because they realize that they have control, a control that neither you nor me have, because neither you nor me know when we are going to die. Neither you nor me know how we are going to die. So we don't have control over this. It is one of the many uncertainties that we have in life, and we need to learn to live with that. Some of us don't think about this. This is the way of dealing with that. Some of us think about this, but we accept this. But the client that decides to commit suicide gain a control that neither you nor me have. And when they gain this control, they know when they are going to die, and they know how they are going to die. They give an empowerment that make them, let's see, happy, because now they know that their suffering is going to end, and they know when and how it's going to end. So they are superior than us, okay? Because they know something that we don't know. You understand? And this is the reason that of the acute change of attitude, of behavior, then you notice the improvement of the emotional improvement that they experience, especially in clients that become depressed, that people that are depressed look miserable, and then suddenly looks elated, looks empowered, looks okay. So and 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 that's why we need to be very aware of those um, details, that those clues that could be given in the test to thinking suicide. So I think that is a question that teaches me, okay, what the cockatoo and the Nclex want, okay, to be answered. If we are aware that suicide is an issue in our clients, and something that we can stop. After receiving the chief at 7 a.m., the nurse goes to evaluate a client with pulmonary hypertension. Pulmonary hypertension is not common, but it's a very serious condition. Remember, there are two circulation, how you call the system in the circulation. The systemic circulation starts in the left ventricle, continues in the aorta, and all the branches of the aorta, okay, all over the body, and returns as a vein, okay, to the right heart, But the right heart sends the blood to the pulmonary artery and to the two lungs. So this is the small circulation, or the pulmonary circulation. This is the systemic circulation. The hypertension that we know in everybody is the systemic hypertension, when the blood pressure is high in the arteries, okay, in the aorta and its branches. The pulmonary hypertension, when the pressure is high in the pulmonary artery, that, by the way, is an artery with normally very low pressures. And that's it. Remember that it is going to end damaging, okay, damaging the right heart, okay, because now the right heart need to deal with an increased workload, because the increased pressure in the pulmonary artery, and it is going to produce mainly right heart failure. Pulmonary hypertension can be primary or secondary. The secondary is the most common. It's seen in people that suffer of chronic diseases of the lungs, COPD, cystic fibrosis are example of chronic diseases in the lungs that produce secondary pulmonary hypertension. But there is a form of pulmonary hypertension called primary that has no problem in the lungs. In the lungs is just a problems in the pulmonary artery in its branches that is seen more frequently in young women, but is rare. It's not common. Okay, just like a very briefly talking about the pulmonary hypertension. It's interesting there is a detail in pulmonary hypertension that a medication that helps to decrease the pressure in the pulmonary artery is the sildenafil, the medication of the Viagra. And you can have, okay, a woman or a child, because in childhood you can have pulmonary hypertension in prematures because the damage that happens in the lungs, okay, because the prematurity. Taking sildenafil, a form of sildenafil for pulmonary hypertension. Okay, very brief on description of what you need to know in related with pulmonary hypertension, which is not a common condition. So remember that pulmonary hypertension produces damage of the right heart, and it's called core is heart, no? Core pulmonale. Okay, pulmonale. Okay. This is the most important that a nurse must know about pulmonary hypertension to deal with questions, English questions. Okay, let's go back to the question. Uh, uh, Receiving at 7 a.m. a client with pulmonary hypertension and right heart failure. How should the nurse explore for pitting edema? The pitting edema is a manifestation of right heart failure and cor pulmonale. Inspect jugular vein region, inspect on lower extremities, press on lumbar sacral area, weigh the clients before breakfast. So if they are asking for pitting edema, how you explore that need to make pressure with your fingers in the client's soft tissues where the liquid is accumulated. But then the question that says that is 7 a.m. 7 a.m. usually the patients are, just getting out of bed after being sleeping, okay, the night. During the night, they are sleeping, and the most dependent part of the body is the butt, is the sacral area. So you don't explore for pitting edema on the legs in a client that you just getting out of bed. You explore for pitting edema in the lumbar sacral area, not in the lower extremities. So this is the purpose of this question, to have this knowledge, and is something that is tested in nursing. Let's see. Klein is a 19-year-old preemie gravida who is at 28 weeks of gestation, second trimester. Physical examination. Client reports constant headache and vision changes. No good. It makes me think in preeclampsia and severe preeclampsia when there are vision changes, okay, and severe headaches could be one of the manifestations of severe preeclampsia, together with the epigastric pain. After 20 weeks gestation, elevation of the blood pressure suggests preeclampsia. Rates headache 6 on 10, described as throbbing and unrelieved by acetaminophen and rest. Client has 3+ pitting edema, an important edema. So another element to think in preeclampsia. Client reports occasional urinary frequency. Well, this is normal in pregnancy. Denies contraction or backache. Is not in labor. The tendon reflexes increase 3+. The normal is 2+. If a 3+ is hyperreflexia, and hyperreflexia is a manifestation of preeclampsia. Client reports a 2.76-pound weight gain in the past week. Important fluid retention. The fetal heart rate is 158, which is normal. Temperature is normal. Heart rate is normal. The client's heart rate. Respiratory rate is normal. The blood pressure is elevated. So now I have the edema. I have the hypertension, in a gestation that is more than 20 weeks. I don't know if it's oh yes, it's primigravida. Remember the eclampsia, the preeclampsia is more common in primigravidas, okay? In headache and visual troubles, I think that we have enough elements to suspect preeclampsia. What is missing here is the proteinuria. Let's see. Urine reagent strip 3 plus protein. So now we have the third element that was missing, the proteinuria. The client has preeclampsia. Preeclampsia. The blood pressure is more than 160 over 100, which is in the criteria of severe preeclampsia, visual changes, and important headache is a criteria severe preeclampsia, and the magnitude of the edema also suggests, okay, severe preeclampsia. There is irritability of the nervous system with risk for seizures reflected by the increased reflexes. So everything translates severe preeclampsia. Casual blood glucose 122, which is casual means that is randomly taken, not in fasting, no? Is not critical. Is not this is not a normal value of postprandial glucose. Hemoglobin 15 and hematocrit 44, 3 por 5, 15, 46. Yes, it sounds that this client has hemoconcentration. It's not usual to see a pregnant woman with 15 grams of hemoglobin. Usually it's in the range of the 12 or lower. So hemoconcentration is a manifestation of preeclampsia. Yeah, and that's why the hemoglobin increases and the hematocrit. Platelet count is low. So now we could be having this variety of severe preeclampsia that have ¿cómo se llama? Low platelets, okay? They help, okay? Hemolysis, elevated liver enzymes, low platelet. This is a severe form of preeclampsia that has activation of chronic or subacute DIC, or disseminated intravascular coagulation, that consumes the platelets. Okay, BUN is elevated. They don't say the creatinine, so we could be having renal failure, acute renal failure, or simply we could be having we could be having we could be having hemoconcentration. Okay, that's why the BUN could be high. We need the creatinine to decide if the client is in renal failure or not. Uric acid is elevated. The uric acid elevate, for your information, in preeclampsia. The protein in 24 hours is pending. Oh Lord, I made a mistake here. I covered, when I copy and paste, I covered the interventions. Okay, complete the diagram by dragging from the chosen. So this is a bow tie type of questions. You see that look like a bow tie? And the first that you need to do is to choose the potential condition. You have urinary tract infection, gestational diabetes, preeclampsia with severe fissures, gestational hypertension. You have preeclampsia. The differential diagnosis could be gestational hypertension. No. A gestational hypertension can appear before the 20th week of gestation. Is not necessarily accompanied by the proteinuria and edema, and usually has no manifestation of severity. So choose preeclampsia with severe manifestation. They say 2 interventions. Administer hypertensive medication, yes. The other one, sorry, being covered here, is administered order magnesium sulfate. This client with severe preeclampsia need to be initiated with magnesium sulfate. Probably these factors were related with the diabetes, administered insulin, or the urinary tract infections, administer antibiotics. No, this is a preeclampsia. And then the other component is parameter to monitor. Two, blood pressure need to be monitored. Dysuria, no. Serum magnesium level, yes, because we initiated, okay? We initiated magnesium, and probably are these two. Urine for bacteria, no, and serum glucose, no. So this is a very easy type of question that if you choose correctly, based in the information in the scenario, the diagnose, you should not be having problem to choose the interventions. The client with Parkinson's disease is prescribed the drug selegiline 5 milligrams twice daily. You need to know selegiline. Selegiline is tested in Nclex. You need to know that selegiline is a monoamino oxidase inhibitors. Okay, and is used as a neuroprotective of the dopaminergic neurons in Parkinson's disease. Summarizing, selegiline is used in Parkinson's, and selegiline is a monoamine oxidase inhibitor, and you should know what are the risks of the problems of the monoamine oxidase inhibitors. While evaluating the client's understanding of the teaching, which statement means that the client requires more teaching. What is wrong in the statement of the clients? I will continue taking levodopa and carbidopa. Okay, usually can be combined. Okay, the selegiline can be combined with the Cinemet. Okay, in client with Parkinson's. I will take it with breakfast and lunch to avoid insomnia. Yes, the monoamine oxidase inhibitors are stimulants of the mood and can produce insomnia. It is correct. I will have a light breakfast with milk, cheddar cheese, and crackers. Remember that cheddar cheese is a aged cheese that contains thiamine. Remember that clients taking, okay, monoamine oxidase inhibitors should avoid food rich in thiamine. The food that is rich in thiamine are foods that have been processed with fermentation. The aged cheeses suffer this process of fermentation. So probably this is the problem. Dizziness when standing up is an expected side effect of the medication is true. They produce orthostatic hypotension, so they need to be very careful when getting up. So summarizing is a classical question of monoamine oxidase inhibitors that you should avoid food rich in thiamine. Based on the principle of pain treatment, which consideration come first? Priority, most important. Treatment is based on patient goals. A multidisciplinary approach is needed. Absolutely. Patient perception of the pain must be accepted. Oh, drug side effects must be prevented and managed. So everything is true. Okay, everything is true because this is should be included. Hi guys, help me. What is the most important? Because the four are correct. What is the most important? What comes first? 1, 2, 3, or 4?
3.
3. Okay, remember, this is the most important. Whatever the client says is pain, and because we cannot evaluate the pain unless it's done through the patient, this is the most important. Okay. My experience with anchors is that this topic, this not this question, this topic, that if you accept that the patient, the perception of the client of his or her pain is whatever and must be accepted, even if you don't believe it. If you see somebody laughing, okay, somebody laughing, okay, and I don't know, watching TV or talking by phone, and they say they have pain 0 to 10, they have pain 10, even if you say doesn't sound logic to me, you need to accept that. And it's the way that is tested in Nclex. They give you this scenario. Somebody that say they have an intense pain, but the behavior is not compatible, is not the usual in with the level of pain. Okay, if you believe and you accept the patient perception must be accepted, you don't question the client's expression of the pain and you give the pain medications as prescribed by the doctor. The home health is interviewing an older patient with a history of rheumatoid arthritis who report feeling pretty good, except for the pain and stiffening in my joints when I first get out of bed, impairing my capacity to dress and prepare breakfast. Guys, this is the classical complaint of clients with rheumatoid arthritis, that the worst moments is in the morning when they have been sleeping and they need to get up. The rest of the sleeping makes the pain and the rigidity, the stiffness of this disease unbearable. And the morning is the worst moment. Okay, and it's a very common complaint. And yes, can limit the capacity to do their ADLs. Which member of the healthcare team will be notified to aid with this pain? Healthcare provided to review the dosage and frequency of pain medications, physical therapy for evaluation of function and possible exercise therapy, occupational therapies to help the client with the morning activities of daily living, home health aid to help patients with a warm shower in the morning. What do you think? So we can rule out, okay, the medication, because the medication is going to be the same in the morning and in the noon and the afternoon. We are dealing here with the symptoms when getting out of bed in the morning. Yes, the problem is that the pain is that I'm feeling pretty good, except for the morning when I get out of bed. So the treatment of the doctor is for around the clock and is what making the client feeling pretty good. The problem is the morning. The physical therapist, okay, is the same as the doctor. It's something that is for all day. Yeah, it's not going to change what is happening in the morning. So obviously, what is happening in the morning is limiting the ADLs of the morning, and also there is something that the somebody can help for this condition. Okay, what do you think? Making between occupational therapists and the CNA are giving a hot shower or a warm shower, because this is the conundrum.
Could be
Don't worry,
three.
say whatever, because remember this is not graded.
Three. I'm taking three.
You are thinking three, makes sense. Okay, it's between these two. I I uh I don't know the answer to this question because it's a question that is coming from somebody that had this experience in his or her English. Okay, so I don't know the answer key. Nevertheless, 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 this is important. You need to know that this pain and this stiffness, this morning stiffness is called seen in rheumatoid arthritis, improve with warmth, improve with exposition to heat. Can be, a blanket, a warm blanket that you can wrap the client. The client doesn't want to shower. Okay, can be, a warm hot shower. Okay, these symptoms improve a lot with this. I remember a question, similar question in English was an adolescent. Remember that rheumatoid arthritis can happen in adolescents, okay? Juvenile rheumatoid arthritis. They had to go to school in the morning and had a lot of symptoms when waking up. And limitation to get out of bed and catch the school bus on time because the symptoms in the morning. And I remember the right answer was wrapping teaching the parents to wrap the boy with warm blankets in the morning before getting out of bed, because it will improve the symptoms. So definitively, what the occupational therapist can do is not to alleviate the pain, is not to alleviate the stiffness, is to I don't know, provide of devices, instruments, etc., to make the dressing and the shower, the cleaning and the preparing the breakfast more, let's see, easier. Yeah. But what could help to this client with the pain and the stiffness in the morning, that is the complaint when getting out of bed, okay, getting out of bed, is the hot shower. So if I were in my anchors, because okay, it is so classical, they use the intervention of using warmth to decrease the morning stiffness and the pain of the morning stiffness, I should preferring 4/3, because 3 is not helping with the pain and the stiffness. It's helping to with the ADLs, yeah, with devices and methods and special instruments, etc. While the help that could improve the pain and stiffening in the joints when first getting out of bed is helping the client when getting out of bed take a warm shower in the morning. And this is what I think. This is what I like to answer in my anchors for that reason. Okay, but you see how anchors make the questions, make you decide between generally two options that are possible. So this is my opinion. Doesn't mean necessarily that I'm right, but this is supported by the book, is supported by the fact that the morning stiffness and the pain improve quickly with warmth more than with pain medication. And what the occupational therapist can do is just to provide zippers in the cloth instead of buttons, um, button hooks to fasten the buttons if the client have the limitations. I don't know, long handle toothbrush to brush the teeth, etc. But this is not going to improve the pain and the stiffness. It's just making the client independent, having the pain and the stiffening in the morning. But what can improve the pain and the stiffening in the morning is the one shower. That's why this is my rationale of selecting 4. Good question, no? Okay. Let's see. Which nursing action is the best example of the principle of of non-maleficence as an ethical consideration in pain management? Okay. Non-maleficence in pain management. Let's see. Patient seems excessively sedated but continues to ask for morphine. So the nurse conducts further assessment and sees alternative to opioid medication. I like it. I like it. Because if the client says in the statement excessively sedated, but is still in pain, to avoid harm, to avoid over sedating and depressing the respiration of the client, I seek for alternative to the opioid. I like it. I like it. Let's see the others. Patient has no known disease disorder and no objective signs of poor health or injury, but reports severe pain. So the nurse advocate for pain medicine. This is beneficence and this advocacy. This is not non-maleficence. There is no problem in advocate for pain medicine in this client because there is not anything that suggests that we are going to harm. So I rule out this. It is advocacy and this is beneficence. Patient is older, but he's mentally alert and demonstrate good judgment. So the nurse encourages the patient to verbalize personal goals for pain management. Okay, this is to promote autonomy. This is also advocacy, but there is no harm here. This is no harm avoided here, so it doesn't apply. Patient repeatedly refuses pain medication but shows grimacing and reluctance to move. So the nurse explained the benefit of taking pain medication. Okay, this is a patient that needs, you have prejudices against pain medication. This is some cultures and some people have this kind of attitude, and the nurse is giving that. But there is no risk of harming there. By the contrary, the patient is refusing medication. Okay, it is beneficence. Okay, so definitively we were right. Number one was the correct. Ethics interpretation is a solid component of Nclex. Scenario. The oncoming day shift nurse has received the shift report from the night nurse. The day shift nurse has done a quick check on all the patients and has determined that all are stable and not in acute distress. In which order would the nurse care for these patients? Okay, we have 5 patients. A 17-year-old adolescent with alert and oriented. He was admitted 2 days ago for treatment of meningitis. He reports continuous headache that is partially relieved by medication. So meningitis produces a headache. The client is in treatment for the meningitis, is receiving probably his or her antibiotics. Yes, but the problem is pain. So here I have, okay, pain. Pain needs pain medication. 65-year-old man who underwent total knee replacement surgery 2 days ago. He uses the patient-controlled analgesic pump frequently and occasionally asks for a bolus dose. Okay, this is on relief pain, and this is relief pain. So one goes before two. Relief, okay, pain. 3, 53 years old woman who is demanding and frequently called for assistance. She was admitted for investigation of functional abdominal pain and is scheduled for diagnostic testing this morning. Okay, this is the problem. It is a client going to test now. And the diagnostic testing could require preparation, okay, preparation. So maybe it gives priority preparation, give priority to this. If this person that is having testing this morning is not prepared, then the test cannot be done, and it's my responsibility to have the test done. 82-year-old woman with advanced Alzheimer's disease who requires total care for all activities of daily living. She will be transferred to a long-term care facility in a few days after arrangements are finalized. So if going to be transferred in few days, okay, is one of the last needs, because what needs is that routine, okay, care. A 26-year-old man who was admitted with chest pain secondary to spontaneous pneumothorax. Today, the chest tube will be removed and the PCA pump will be discontinued. We need to prepare, okay? The doctor is coming to remove the chest tube. Okay, so the pneumothorax is not the problem. It's the chest, the removal of the chest tube. This is remove the chest tube. Okay, and the PCA will be discontinued. Okay, so we have on relief pain, and we have a client that needs pain medication, and we have a client that we need to assess for preparation for a test. Okay, before that. So I think that the on relief pain should be one. Let me change the color. Should be one, because you need to give the pain medication. Second is the client going to a procedure that you need to see if the client is prepared. Okay. The next that you need to prepare is the client that the doctor is going to come to remove the chest tube. You need to be sure that the X-ray is done and the equipment to remove the the tubing is ready. Then you have the client, okay, um, that has relief pain, and the woman with routine care that is going to be transferred in few days. So whatever the clients can request, okay, bolus could be the next, and the last is the client that is going to be transferred in few days, because you have plenty time to prepare the transfer, and it's going to be a bureaucratic, okay, care. So I think this is the order. Do you agree or you disagree with me?
I agree.
Okay, so we are good then. Okay, so remember there are a lot of questions in Nclex that cannot be answered with knowledge or with the book, need to be answered with common sense. Okay, the only bad of these questions is that take time, okay, to read and understand. Another weird question. The nurse supervisor has advised the charge nurse that there is a new admission who needs a private room. The charge nurse must review the conditions and the statuses of the patients that are currently on the unit to determine who could be moved and placed in the same room. So you need to move a client from the room the client is to another room that is going to be shared with another client to make a space, okay, to leave one room empty. Which two cancer patient could be cohorted? Okay, let's see. Patient A has a neutrophil count of 1,000 per cubic millimeter. Okay, so it is a client that has a neutropenia, should be left alone. Patient B underwent debulking of a tumor to relieve pressure. Debulking is a surgery where they trim a tumor that cannot be operated. It's not surgically cannot be removed, but then they trim, okay, the part of the tumor that can be removed. Okay, so it is a client that just is post-op. There is no contraindication to be with other client. Let's see. Patient C just underwent bone marrow transplantation. This is also immune suppressed. Okay, this client is receiving immune suppressive therapy. Is like A, should be alone. Patient D has a laminectomy for a spinal cord compression. It's very similar. It's very similar to two. So a client has a surgery in the vertebrae because it has a tumor in the spinal cord that comprimes, is compressing the spinal cord, and is a post-op or the same surgery. Sounds that they are two good candidates. Patient E underwent brachytherapy for prostate cancer. Brachytherapy is a radiation, and the client has some, depends. There are low radiation, high radiation brachytherapy, so depends. Okay, the brachytherapy, the implant is left in the prostate. So the prostate has some little pieces of metal that is radioactive inside the prostate, so there is radioactivity. So the client should be alone. Patient F has terminal cancer and is receiving end of life care. This is a client that is dying. The family should be there saying goodbye. It's a very private situation, should be alone. Patient G is approaching the nadir associated with the chemotherapy treatment. When you receive chemo, the white blood cells drop. And the nadir is the moment in which the white blood cells are the lowest. So it's a client like A, is neutropenic. So obviously we were easily moving together the two post-surgical, and we are leaving one room available for the admission. Again, it is with minimum knowledge where you can answer this kind of question. Guys, in your test, take your time to analyze the question. Don't exaggerate, don't procrastinate, but take your time to analyze the question. A patient diagnosed with acquired immune deficiency syndrome with but without respiratory symptoms is an 8, no? But without respiratory symptoms has a 6 millimeter in duration at 48 hours after a skin test for tuberculosis. With action will the nurse anticipate taking next? Asymptomatic, immune suppressed, PPD, 6 millimeters. What you do next? Arrange for an X-ray to check for active TB. Tell the patient that the TB test is negative. Refer to initiate multi-drug treatment for TB. Schedule TB skin testing again in 12 months. There is no need of repeating the TB skin test because this TB skin test is positive. But there is no need of initiating treatment because a positive TB test doesn't diagnose tuberculosis. Okay. Um, you don't tell the client that it's negative because it's positive. Anything that is more than 5 in a client that is immune suppressed is positive. So obviously, what the patient needs is more study. The patient needs an X-ray and needs a sputum. The X-ray and the sputum will decide if the client is active, is contagious, and require treatment. The last. The RN is admitting a patient with benign prostatic hyperplasia to an acute care unit. The client describes an oral intake of around 1,400 milliliters per day. What is the RN priority concerns? Okay, so 1,400 milliliters per day is too little. Should be drinking at least 2,000. No? Ask the patient about his bowel movement. What have to do? Have the patient complete a diet diary for the past 2 days. What have to do? Intro the client to increase oral intake. Yes. What color is white horse of Napoleon? Ask the patient to describe his urine output. No, this is the most important. Okay, guys, this is what we have for today. Do you have any question? Do you have any suggestion? Do you want anything else to do in the future? Are you okay?
Yes.
You okay? Are you studying? Are you ready? Are you ready studying for your NCLEX? Or you are still dealing with your final tests in your last semester? What are you doing?
I'm studying for Nclex.
Okay, this is the attitude. Okay, this is the attitude. Okay, good. Okay, guys, God bless you. See you next time. Don't save. Let me quickly download the attendance. Okay, people. Download the attendance. Okay, guys, see you next time. Thank you for your attention. Bye bye.
Bye bye. Thank you.